Okay, I don't think that's going to work perfectly, but hopefully people online can see that presentation. They may see a little more information uh, than the people in the room, but here we go. Um, so today I'm going to be talking a little bit about infection-associated chronic conditions and long COVID. The goal here is to talk about a few things. First, how we diagnose. So when we're thinking about a patient in front of us who is experiencing some of these extremely debilitating symptoms associated with infection-associated chronic conditions, how are we diagnosing? How are we thinking about the conditions? And then the next step after diagnosis is thinking about, okay, what may be going on inside of this person's body while they're experiencing these symptoms, so the pathobiology. And then finally, we're going to talk a little bit about what to do about it, given that these things are happening, given that we have good science to support some of the pathobiology moving forward. How do we actually implement some interventions to try and stop things in their tracks? So let's start off with a brief working definition of an infection-associated chronic condition, and then some conversation about how to diagnose. And I really appreciate the fact that there are so many members of the patient community in the room. I apologize that we may be going a little technical here because this is a CME accredited course, but I also know that if you're anything like the folks that come to our clinic in New York, you probably know more than me anyway. So I'm probably speaking your language. So let's keep it simple with a working definition. When we talk about infection-associated chronic conditions, we're talking about disease states that emerge when someone fails to return to their pre-infection health status after an infection event. To make that even more simple, if you get sick with something and you fail to fully recover to where you were before you got sick with that thing, you can be thought of as having an infection-associated chronic condition. And I also want to point out that under this definition, infection-associated chronic conditions have been described for decades as a result of various viral and bacterial triggers. In 2022, there was a wonderful paper that was published in Nature led by Akiko Iwasaki at Yale University in partnership with the patient community, where she cataloged various viruses that have been documented to have associated infection-associated chronic conditions. You can see a table from this paper here. What is really striking about this is many of these conditions don't even have names. So there are evidence-based bases for the fact that things like Epstein-Barr virus will create long-term chronic conditions in a small percentage of people who get an Epstein-Barr virus infection, but we don't have a name for that, right? So despite the fact that these things have been acknowledged for a while in the consensus science, in the medical world, we're not making diagnoses based on these things and then going after intervention. So I think that this was a really important paper to really shine a light on the fact that this has been around for a while, this phenomenon, and there are many things that can trigger an infection-associated chronic condition. This particular paper focused entirely on viruses, but I think we also need to be aware of the fact that bacteria can lead to IACCs as well. I think one of the most prominent examples of this is chronic tick and vector-borne illness. So when we think about things like chronic Lyme disease, these are a subset of patients who have been bitten by a tick. They've been confirmed as having a Borrelia infection. They've been given the standard therapy for a Borrelia infection, which is doxycycline, and they have failed to recover to their pre-tick bite health status. We also have in the pediatric world conditions like PANS and PANDAS, where kids have developed a strep A infection and then gone on to develop severe neuropsychiatric symptoms such as OCD without a good reason except for the infection, this has been documented as a trigger for PANS and PANDAS to develop. So these are diagnoses that we've known about for decades, I'm encouraged by the fact that long COVID has really accelerated our understanding of infection-associated chronic conditions to the point where we're really not able to ignore this anymore. Action needs to be taken, and a lot of interventional research is starting up, which is exciting to see. I think a reason that we have for a long time ignored IACCs or minimized IACCs is because the symptoms can be extremely varied. So when it comes to diagnosis, a lot of people kind of other IACCs because of the diversity with which people can present with symptoms. If we just take the example of long COVID, this is a paper that was published early in the pandemic. A patient-led community put this together in 2021, which this was published by the Patient-Led Research Collaborative, where they interviewed several thousand people with long COVID and cataloged symptoms. This was before the NIH had put their pants on. We weren't even talking about Recover. These guys were out there doing it with no funding. And they cataloged over 200 symptoms that could affect every single organ system. One of the most impressive things here about this work was just how varied a presentation can be when someone steps into your office with a suspected long COVID diagnosis. And the reason I show this is because this can make it feel like it's complicated to diagnose infection-associated chronic conditions. I'm trying to really put the idea out here that it's not that complicated. So when we're thinking about how to diagnose an IACC, my general advice is keep it simple and follow the existing guidelines, because there are existing guidelines and they're pretty well written as well. So let's start with long COVID. And I want to point out that the National Academies of Science, Engineering, and Medicine has the most up-to-date guidelines. They put together, a sort of a guidance statement that was 50 to 60 pages long. For anyone who has the time, I recommend the read because I think that they did a really good job on it. But I'm not going to talk you through 50 to 60 pages. I'm going to give you the head notes. And really, what they're talking about is the fact that long COVID is an infection-associated chronic condition that can be diagnosed when someone has a confirmed or suspected SARS-CoV-2 infection. And 3 months beyond that infection, they're still experiencing symptoms that were not part of their normal health prior to the infection. I really want to point out some of the language used here because the symptoms don't need to be continuous. So they can be continuous, they can be relapsing remitting, or they can be progressive. So it's really important to note that long COVID, again, doesn't always look as though you have to be completely under the weather and incapacitated the whole time in order to get a long COVID diagnosis. You can have several good days in a row and then crash. And in fact, some of your symptoms can go away for a couple of weeks and then come back. But if you're not really feeling as though you've made it back to your pre-COVID health status, then that's when a long COVID diagnosis can be considered. I also want to point out the fact that the National Academies of Sciences really zoned in on a few things that I thought were important, highlighting the fact that you can have a single symptom or you can have many, many symptoms. So there's no number of symptoms needed for a long COVID diagnosis. It's the fact that you have not fully recovered from that infection event. They also point out that in addition to your long COVID diagnosis, you can have other diagnosable conditions that have been caused secondary to the COVID infection. So you can also get a new onset diabetes diagnosis. You can also get other diagnoses that already exist with existing ICD-10 codes that are secondary to your long COVID diagnosis. And I think that this is an important point. And then I think probably the most important point is the fact that we are guided by both the CDC and national academies to make the diagnosis on clinical grounds. So you do not need a biomarker to make a long COVID diagnosis. I really, in all of my CME courses, I try to harp on this because this is the number one reason that we see in our clinic that short and long-term disability benefits are denied. Show us the biomarker of long COVID. And we always reply, per CDC and National Academy's guidance, we don't need one. We're the biomarker. Our patients are the biomarker. You know, we're making the diagnosis based on a clinical basis, which is the guidance of the federal agencies. And, you know, we often like to remind people that we don't make other diagnoses. There are many diagnoses that we can make without biomarkers, such as depression and other mental health conditions. We don't need to say, here's the blood test saying that you have this diagnosis. This is a really busy slide, and I promise not to read through it all, but if you want to take a photo of it, that's totally fine. But when we start to talk about diagnosing chronic tick and vector-borne illness, I want to share again that there are guidelines for this. And this is an update of the existing guidelines that have been out for a while. This is by Brian Fallon's group. This is the most recent update of the guidelines that is in press at the moment. It's been accepted for publication, but so you're getting a little bit of a sneak peek. But in general, the way that the clinical trial network at Columbia University think about the diagnosis of a chronic tick and vector-borne illness is they have different groups that assign different levels of certainty to the diagnosis. So it is perfectly acceptable if anyone falls within group 1 or group 2 to make a chronic Lyme disease or post-treatment Lyme disease syndrome is the actual ICD-10 code diagnosis. If someone is in group 3 or group 4, it may be more appropriate to suspect the diagnosis, but maybe not yet make the diagnosis and maybe search to see if there is a better diagnosis that explains things. But essentially, what we're talking about here is if you're in group 1, that means that you have had a positive blood test for a Borrelia infection. You have had a very obvious rash associated with Lyme disease. You have gone on to have standard of care for your acute Lyme disease, and you've failed to recover from, from that initial tick bite. Group 2 is a little bit more lax. So there was definitely, there can be multiple conditions. So you can definitely have a tick bite. You can definitely not feel well after that tick bite, but you don't necessarily need to have a positive blood test. We know that blood testing is imperfect. And it's a bit more of a mix and match of the different symptoms. So for instance, you may not have noticed a tick bite, you may not have pulled a tick off of your body, but you got the rash, from the bullseye rash from that is associated with Lyme disease. Or you did see the tick bite, but you didn't get the rash and you didn't test positive, but you felt terrible since you got that tick bite. So this has been a really challenging thing to pull together in terms of diagnostic criteria, but again, there has been some fairly solid medical consensus on this, and the publications are out there to support this as a guidance for making diagnosis of chronic tick and vector-borne illness, specifically for chronic Lyme. We'll talk about other tick and vector-borne illnesses in a couple of slides. Finally, ME/CFS diagnoses. Our team, there are different criteria out there for diagnosing ME/CFS. Our team uses the Canadian consensus criteria. And so when we're making a diagnosis of ME/CFS, what we're looking for is, any one of these symptoms that are being named along the continuum here. So people reporting fatigue, people are reporting post-exertional malaise, sleep disruption, myalgia, so, muscle pain and body aches. You also need to be reporting, cognitive symptoms and neurological symptoms and symptoms that fit certain categories like autonomic dysfunction. Yes? Oh, I'm sorry. ME stands for myalgic encephalomyelitis / CFS, chronic fatigue syndrome. And we shorten it to ME/CFS because that's a lot of words to say. But thanks for asking. In addition to the symptoms being reported, there's a couple of other things needed for an ME/CFS diagnosis. First is that the symptoms need to be new onset. Now, I want to really make the point that when I say new onset, someone can still come in and say, I've been really unwell for 15 years and no one's ever given me a diagnosis. But there needs to have been a point where they were feeling pretty good. And then there was an event, and then these symptoms came on. And that makes them eligible for an ME/CFS diagnosis via the Canadian consensus criteria. The next condition in the Canadian consensus criteria is ruling out mental health diagnoses. And we often see this quite frequently. You know, we're having a subjective interview of the patient, and they'll say, yeah, you know, like 5 doctors told me I was mentally ill. I tried antidepressants. It really didn't do anything. I tried cognitive behavioral therapy. It didn't do anything. You know, you can look at my medical record. That's ruling out a mental health diagnosis. Ineffectively treating a mental health diagnosis is ruling out a mental health diagnosis. And the other piece, and again, I know that this is dry, but this is really important. This is the really important stuff. The other piece that is important for making this diagnosis is ensuring that the functional impairments that are being reported from the symptoms. So someone says, I'm fatigued, sleep disruption, post-exertional malaise, et cetera, to meet criteria for ME/CFS diagnosis as a Canadian consensus criteria, we need to see on the SF-36, which is a patient-reported outcome of functional limitations, we need to see patients dropping below normative thresholds in at least 2 of the 3 categories, meaning that it's not just you're feeling symptoms. Those symptoms are interrupting with your ability to conduct daily life in a measurable way. Now, again, for most people with ME/CFS, this is not an issue. We can very clearly show that on the SF-36, but it's an important part of making the diagnosis. And so Canadian consensus criteria are quite exacting and quite strict, but they do allow us to make good quality diagnoses that are defensible, so that then when we're fighting with insurance companies, which we spend a lot of our time doing, you know, we've got really clear-cut guidelines on how we made the diagnosis, and we've got answers for them when they say, you know, well, how fatigued is too fatigued? You know, well, we can see it's too fatigued because on the SF-36, it's interfering with their daily function. And those are the sorts of answers that really quiet down the insurers and help us to get coverage, because, you know, we want to be able to have smart, objective answers to why are you doing this treatment? How is this treatment helping? And in poorly characterized illnesses, that has been the Achilles heel for a really long time, is people just writing down patient reports fatigue, as opposed to patient scored this much on the fatigue severity scale. And when we started this treatment, their score went up by 20%. So I lied to you a little bit that we can keep things simple, because there is complexity around the diagnosis of infection-associated chronic conditions. The first part of the complexity that I want to talk about is the fact that sometimes an infection-associated chronic condition may not necessarily be so proximal to an infection, or you may have trouble confirming the infection. So obviously, in a perfect world, someone gets SARS-CoV-2, they test for it, we've confirmed the case, we know that they had COVID, they go on to develop persistent symptoms, we can make a long COVID diagnosis. That is a terrible situation for the person, but from a diagnostic standpoint, that helps us along. In many, many cases, which are increasing now that, you know, the CDC has sort of said, hey, let her rip, and it doesn't really matter if you get COVID. So people aren't testing that much anymore. So now we face a situation where we may not have a confirmed infection. So what we guide, and what CDC and what National Academies guides upon, is clinicians making their best guess about what may have been the infection. So if you sustain an infection and you say, doc, 6 months ago, I got this thing, blinding headache, couldn't smell a thing, and fevers, and I recovered, but now I've got post-exertional malaise and fatigue and migraines. That physician might say, well, that sounds as though you had COVID because of the loss of sense of smell. So I'm going to say suspected COVID infection, and now you have long COVID diagnosis. However, someone might also say, well, I got sick with something. I was down low, like my GI upset, and I don't know, I was just like not feeling great, very fatigued for a couple of days. That could kind of be anything. But if they've had symptoms now for 6 months, 8 months, 9 months, the physician may choose to use Canadian consensus criteria to say this is an ME/CFS diagnosis, because we can't be sure of the infection, but it was an infection-triggered illness that has gone on. And then I also want to make space for an even more complex condition, which does happen. It's rare, but it does happen, where infection-associated chronic conditions can be triggered by non-infection events. Now, there is ongoing research that is occurring here, and we should be aware of the ongoing research. But when I talk about non-infectious events, I'm talking about physical trauma, things like car accidents, concussions, talking about intense stress, prolonged periods of intense stress. We're talking about immune challenges like moving into the second or third trimester of pregnancy. We're talking about chemical and toxin exposure. These are things that can bring out these infection-associated chronic condition-like symptoms. Now, the rationale for this, how this might happen, is what we call the successive hit or multiple hit hypothesis, meaning that your immune system can take multiple hits. And so maybe you got sick with COVID, you fully recovered, or you felt fully recovered, but under the surface, it was kind of smoldering and it was causing immune dysregulation and all sorts of chronic inflammation. And then the next hit, the car accident, the concussion, getting pregnant, whatever the next immune hit was, tipped you over the edge into this infection-associated chronic condition disease state. So that may be going on. Or it could actually be that sometimes these neuroimmune conditions can be triggered by other non-infectious hits. Like I said, the research is still ongoing, and I think we need to make space for this. I sometimes go as far as to say infection or exposure associated chronic conditions because of the pathobiology that I'll get into after, can feasibly be caused by non-infectious hits. But right now, it's just important to note that this can happen. It's less common, that we can't link it to some sort of infectious event, but it can happen. The next bit of complexity that I want to bring to the table is the fact that sometimes you can have something that very obviously looks like one IACC, but may actually be another. For that case, I just want to share, a really interesting case study that was published last year, where an individual came to the doctor. They had had a SARS-CoV-2 infection. They had felt terrible, for months after their SARS-CoV-2 infection. Went to the doctor. The doctor was like, well, of course, long COVID, and made the long COVID diagnosis. Attempted to manage long COVID symptoms, and the patient just wasn't doing any better. This physician chose to then test the patient for evidence of chronic Bartonella infection and saw that, yes, in fact, this person's Bartonella titers were through the roof, treated with a combination antibiotic for Bartonella infection, and patient's symptoms fully resolved. So here we have a situation where, just like I was saying before, you can have something smoldering under the surface until the next hit comes. SARS-CoV-2 triggered all of these symptoms, but it was actually the Bartonella infection that stuck around and was causing problems. And so addressing the Bartonella infection dealt with the symptoms that were triggered by the SARS-CoV-2 infection, which was a really interesting case study. But these are things that we're seeing more and more, and we're actually doing a lot of research now into co-infections and the role of co-infections in disease burden in folks with long COVID and other infection-associated chronic conditions. Okay, I'm making lots of room for complexity, as you might know, because there's a lot of, complexes in the name. So, the other thing that I just want to talk about is how little we know. So I was just talking about, guidelines for diagnosing chronic Lyme disease. Chronic Lyme disease is when you have a chronic Borrelia infection or you have chronic symptoms as a result of an acute Borrelia infection that never resolve. But I want to point out that ticks are terrible creatures and they carry all sorts of other infections that we know to be damaging and we know to cause all sorts of problems for the human host. So, we also need to just understand the fact that there are just so many more infection-associated chronic conditions out there that haven't gotten any attention whatsoever. We have had this, we've had this terrible culture right now of, if a tick bite occurs, we get tested for Borrelia. That's what we get tested for. And the typical labs out there actually don't even do a good job of testing for all the species of Borrelia that exist. So we get tested for a very narrow spectrum of just Borrelia if a tick bites you, despite the fact that, this is an image that's adapted from a good systematic review that was published in 2020 of all of the bacteria that we know ticks carry. And there are testing clinics out there. I'm not naming these clinics because we have any sort of financial conflict of interest. I'm just naming these clinics as these testing paradigms because these are some of the ones that are out there that routinely have shown the best results in clinical trials. But there are groups like Galaxy and IGeneX that have testing kits for other tick-borne illnesses. And we routinely use these in our clinic to be able to test not just for Borrelia, but for Bartonella, Babesia, Rickettsia, etc. And we still need evidence-based therapies for these patients. Our physicians are sort of scouring through the latest, case studies or case series that are available for this, but we need a larger movement of national attention because not only are these illnesses important for the folks who are living with them from, tick and vector-borne exposures, but we're also starting to see evidence, such as the previous slide, that these are relevant to folks who are getting symptoms triggered by other infections. So there's a great researcher at MIT by the name of Mickey Tal who has published a lot of papers showing that in many cases, a single pathogen alone is kind of harmless and it just hangs out in your body. And yes, it does persist, but it doesn't really cause any trouble until other pathogens show up. And it's actually the combination of the pathogens that start to cause a lot of trouble and a lot of immune burden for the host. So these are some of the things that we need to start considering as we think about how to manage and how to care for these patients. And I will just move on from there because I know we're short on time and we've got so much to cover. So we're going to dig into the pathobiology of infection-associated chronic conditions. What's happening in the bodies of people that are living with these conditions? And so, in 23, Akiko Iwasaki and myself published this paper in The Lancet, really talking about what we thought were some of the most likely drivers of the pathobiology of long COVID. We were talking about persistence of viral reservoir. We were talking about reactivation of latent infections, autoimmunity, and then all of the different ways that the virus caused damage and disruption to homeostasis in the body. And we also sort of built out this cogwheel model because we wanted to indicate the fact that these pathobiologies are constantly interacting with one another. So intervention is a moving target because the pathobiology is sometimes also a moving target. But I want to just take some time to go through all of these different pathobiologies because I think it's important to not only talk about them, but to point out that there is strong quality consensus science on each of them. So this is a paper that we published in Nature Immunology just last year, where we pulled together all of the evidence for SARS-CoV-2 persistence in people with long COVID. And we were showing that there's, again, a number of high quality clinical trials that have not only identified persistent SARS-CoV-2 in people with long COVID, but has also shown that that the persistent virus is actually doing something in the bodies of people with long COVID and actually causing increased symptom burden. The last study that came out to this end showed that at least 40% of people with long COVID we were able to see evidence of circulating spike protein in their plasma. Now, circulating spike protein is a part of the virus. It's not the whole virus. But this is a question that I always get. If viral persistence is so clearly happening, why don't we have a test for it? And the answer to that is because right now, the sort of like gold standard for testing for infection is testing in the blood. And what we're seeing over and over again in all of these studies that are getting published is actually when a virus goes into a sort of chronic persistent state, the blood is the last place you're going to find it. It actually tends to hide in tissue. SARS-CoV-2 specifically likes to hide in neural tissue. It likes to hide in gut tissue. These are some of the areas where we're finding the biggest reservoirs of SARS-CoV-2. And each virus has its preferences, for where it's hiding. But very, very rarely does it hide in the blood, because in the blood, that's where all the white blood cells are going to come and get it, right? So if it is persisting, it's hiding out in tissue, not in blood. And so a lot of the work that we're doing is rapidly working to validate biopsy techniques where, if someone could come in and you could take biopsies from areas where we know reservoirs to be hiding, you can be testing and you can go, you can move along from there. Also, I will point out that biopsies themselves are imperfect because by definition, you're taking what you hope is a representative sample of the tissue. So there's also some really amazing work happening across the country looking at sort of radioligand traces that can tack on to pieces of virus so that you can then do like a PET MRI or some sort of imaging technique to actually look for where these, evidence of these pathogens might be lighting up in the body. So the sort of takeaway from this slide is there's a lot to do, but viral persistence as a driver of infection-associated chronic condition, at least a subset of people with IACCs, is at this point a scientific certainty. The next sort of questions are, what do we do about it in terms of how do we treat it? And also, how do we up-level our diagnostic techniques to actually be able to make mainstream testing available to patients so that we can move into precision medicine? We also published in Nature in 23 showing that in comparison to healthy controls, people with long COVID have a high proportion of people with long COVID will also show evidence of reactivation of latent viruses. CMV, Epstein-Barr virus, a variety of herpes viruses are reactivating in the bodies of these folks. We're currently in collaboration with Akiko Iwasaki's team at Yale to replicate these findings in people with pre-2020 ME/CFS diagnoses so that we can compare and contrast the immune findings and see where there is agreement versus differences in the immune profiling of people with pre-2020 ME/CFS diagnoses. But we certainly know that reactivation is a very clear factor in folks with long COVID. This is a paper that I really want to highlight. I think it was one of the most important papers of 2024. It was published in Nature Communications by Rob Wust's group in the Netherlands. And this is, as far as I'm concerned, this is the paper that should have put to bed anyone who says, oh, you're feeling fatigued and you have post-exertional malaise, get out on a treadmill, go for a run, maybe have some cognitive behavioral therapy, and you'll bounce right back from this this funk that you're in. What this paper did was it showed that if you put healthy controls on a treadmill and got them exercising in a submaximal fashion, so it was moderate intensity exercise, they were able to have a comfortable conversation as they were exercising, and then you took a muscle biopsy, we weren't able to see any evidence of muscle pathology as a result of that submaximal exercise. We weren't able to see any proteins associated with mitochondrial dysfunction or metabolic dysfunction. By contrast, when Rob's team put people with long COVID on the treadmill, specifically people with long COVID who screened positive for post-exertional malaise, that symptom of post-exertional malaise, put them on the treadmill, exercised them submaximally, took the muscle biopsy. What we see here, and it's stained up in the light green, is amyloid proteins forming almost immediately in their muscle, indicating metabolic dysfunction, indicating damage to the muscle that is outside of the range of what you would expect for submaximal exercise. This is the paper that put to bed the fact that a post-exertional malaise is driven by deconditioning. You do not see this in deconditioning. What you do see this in is mitochondrial dysfunction and overall metabolic dysfunction. The fact that these folks' energy systems, their methods and modes of producing energy have been broken down or disrupted. So a really important paper that was published. We also saw in 2023, we published in Nature this idea that folks with long COVID have hormonal dysregulation compared to their healthy control counterparts. So one of the hormones that was significantly out of range was morning cortisol. Cortisol is a really interesting hormone. It controls immune function. It also controls wakefulness. It's the thing that wakes you up in the morning. So what we expect to see is in the morning, we expect to see your cortisol levels spiking because that's what brings you out of sleep and makes you be able to function like a human in the morning. In folks with long COVID, we saw significant decreases in their morning cortisol spikes. We're just wrapping up a study now where we've actually done a full diurnal cortisol metric in 100 folks with long COVID and 100 healthy controls, so we can actually track the patterns, and we're seeing replication of these findings. But suffice to say right now, hormonal dysregulation is definitely a part of long COVID pathobiology, and we also think other infection-associated chronic condition pathobiology. It goes further in that we see that men and women have different symptom presentations that are sex-linked. As you can see, this is a graph that sort of scatters down, like on the left, you see the symptom name, and then you see in the blue, this is Akiko's team bucking gender roles, but in the blue, these are symptoms that are more linked to females, and in the red, we're seeing symptoms that are more linked to males. And what you can see is that in certain symptoms, there are some really nice separations between these are almost exclusively reported by men or exclusively reported by women. I'm sorry that some of you may have to squint on this, but you can also check it out. It's already, if you look up my name and Akiko's name and sex differences in long COVID, it's pre-printed and it's under review at Nature right now. So this was a really interesting finding to see that symptoms present differently. But it was also, interesting to think about why. Because even in the news today, there's been this new paper that came out from the NIH saying that women are more likely to get long COVID than men. This has been in the news with ME/CFS as well for decades. Women are more likely to be diagnosed with ME/CFS than men. And for decades, if you asked why, the answer that you were given was, well, who knows, and I'm not making this up. I'm not being glib. This is what was published to explain the differences. Women are more likely to have diagnoses of anxiety and depression, and therefore it makes sense that they would also get a diagnosis of ME/CFS. These were the finest minds at our government institutions researching the topic. And if you were to ask a sixth grader in health class, is there a hormonal difference between men and women? And what is that hormone? The sixth grader would probably say, yeah, testosterone. And so when our team looked at testosterone levels in women with long COVID, we saw that they were significantly reduced compared to healthy controls. Not only did we see that testosterone levels are reduced in women with long COVID, but we also saw that the lower their testosterone levels went, the more severe their symptoms became, and actually the more pronounced the sex-linked symptoms became. So they looked more like the female version of long COVID, in terms of the symptoms that they were reporting. Similarly, in men, we saw that men's estradiol levels were lower than men without long COVID. So what we actually interpret this to be is, and this is me, just to be clear, this is me outside of the study conjecturing, and we're looking to sort of, confirm this with future studies. But when I think about estradiol in men, I also think that this is probably low testosterone, because men produce estradiol by converting testosterone to estradiol, and men often have a wide range of testosterone. So women, the sort of range of normative testosterone levels are quite small. In men, it can be quite large. So what could be happening in men, which mess up our numbers, is someone, with very high testosterone levels pre-COVID, went on to develop long COVID, and they did experience a big drop in their testosterone levels, which they're probably feeling, but they're still testing normative. Whereas where we see the change is in how much testosterone they're turning into estradiol. And so that's how we're thinking about it right now. Of course, again, that's conjecture, but we're looking into it. And in the meantime, this opens up actionable strategies for intervention, with hormone replacement therapy and different hormonal therapies with endocrinologists. And I can say anecdotally within our clinic, when we see hormonal levels completely out of range in our female patients, referring them to endo and getting some testosterone cream or something of that nature can actually really give a lot of our patients a boost. It has to be done under supervision, but it's worth a try. I also just want to point out that there is a large body of evidence. This is a really great paper to look into as a systematic review of all the ways that COVID can cause damage to blood vessels, and then the formation of microclots and platelet hyperactivation. We also see this occurring in ME/CFS and chronic Lyme disease, but the microclots are much smaller than what we see in long COVID. So endothelial dysfunction and microclot formation is definitely something that is strongly linked to long COVID pathobiology, but may also have links to other infection-associated chronic condition pathobiology as well. There are many interventions that can address this, which we'll get into in a few slides, but it's definitely worth staying on the radar. And there's some robust literature now, and I do recommend this publication that we put out in 24 that really reviews all of the literature. The final two slides are the scariest, and I apologize for that, but we got to speak the truth. The first is to just talk about the fact that what we're learning in terms of SARS-CoV-2's effect on the central nervous system is that even mild acute illness can cause neurological damage, even if you don't have a long COVID diagnosis or don't feel as though you're experiencing persistent symptoms of your acute SARS-CoV-2 infection. So this is a study that we published in 22 with, it was a cross-species study with some amazing collaborators at Stanford, Michelle Mongi and her team, where we showed that mice who had an acute mild SARS-CoV-2 infection developed this small chemokine called CCL11 that caused damage to the central nervous system and measurable damage to their white matter in their brain. We also found that chemokine in people with long COVID who had significant cognitive impairment, indicating that SARS-CoV-2 infection was causing this sort of chemical inflammatory cytokine and chemokine release that even if the acute infection was very, very mild, could still cause central nervous system damage. This study was recently followed up with an even scarier study in 24 showing that looking at a giant brain bank data set that had been following cognition across age in hundreds of thousands of participants for many, many years, including prior to COVID. This study showed that with every SARS-CoV-2 infection that you survive, regardless of your long COVID status, if you just survive a SARS-CoV-2 infection, on average, you lose around 2 to 3 IQ points. So infection prevention is key here, everyone. What we want to be doing is, even if you're believing CDC messaging on a SARS-CoV-2 infection is no different from the flu, you're still not getting the flu 6 times a year. The flu is a 1-time-a-year thing if you're unlucky. SARS-CoV-2 infection, we have people getting it 6, 7 times a year if they're not being cautious. And according to this latest study, that means 21 IQ points a year. That's not great, right? Now, I know that's not how statistics work, so don't kill me on that. But the point being, there is cumulative damage that we're not necessarily seeing, and infection prevention is important because we still have a lot to learn about this virus. The final piece of pathobiology I want to share before we move into interventional strategies is some really beautiful work that was done by Kayla, who's there in the bottom left. What Kayla did was bottom right. Sorry. What Kayla did was she took IgG, so antibodies, from healthy controls, people who had never had COVID, convalescent controls, people who had COVID and fully recovered, and people with long COVID who we had diagnosed very carefully. And the first thing she did was she showed that the antibodies that she took from people with long COVID would preferentially attack human neural tissue. So meaning that there were autoantibodies present in that in those antibodies that would be reactive to nerve tissue in humans. So there's something going on in at least a subset of folks with long COVID that leads to autoantibody activity that attacks tissue around it. The next thing that she did was she injected these antibodies into mice. And what she started to see is that the mice who received antibodies from people with long COVID experienced deficits in balance, experienced deficits in grip strength, and also experienced increased pain sensitivity. And the craziest part of the work that Kayla did was that when we separated out, in this particular case, the pain case, when we separated out the people with long COVID who reported new onset pain from the people with long COVID who said, well, I've got all of these other symptoms, but pain isn't one of them. What we see is that the mice that received antibodies from the long COVID patients with new onset pain over here were the mice that got new onset pain. And the mice that received antibodies from long COVID patients who didn't have new onset pain, they didn't get that symptom. Not only can we passively transfer autoantibodies that are causing damage to the mice, but we can passively transfer symptoms. So once again, anyone who's saying that this is a psychological illness, anyone who's saying that it's not real, okay, I've got an injection of antibodies to give you if you're feeling brave, but what we're seeing here is very clear evidence that that this is something that can be passively transferred. And from a public health standpoint, there are 2 things that we should be ruminating on with this finding. The first is it opens up treatment avenues. The first and most important. We have things like FcRn inhibitors that can preferentially target functional autoantibodies and suppress them. So our team is trying to work with companies that produce these things to see if we can actually get some clinical trials going on that front. The second thing from a public health standpoint is we need to start thinking about the fact that if someone has a diagnosis of an infection-associated chronic condition, should they be able to donate plasma? Because this can be passively transferred through plasma. So we need to be careful about this. We need to be thinking about, again, the problem with psychologizing an illness that is so clearly physiological is that it affects all of public health, whether you like it or not. And just one small piece of wisdom here is that I think because they were probably scarred from, the outbreak of mad cow disease back in the 90s, in the UK, you're not allowed to donate blood if you have a long COVID diagnosis. That was put into place very early in the pandemic by the UK. I would suggest that these are findings that suggest that we should be thinking along the same lines, and clinicians should potentially be advising along the same lines for folks with infection-associated chronic conditions here. Although I will say out loud that there's not a whole lot of people with IACCs who donate blood because their POTS usually makes it pretty untenable for them. So we've been given a small mercy there, but it's just something to be considering and thinking about as we uncover the pathobiology. So we'll stop there on pathobiology, but just the final comment is I hope that I've impressed upon you how complicated this is and how so many of these things can be happening all at once. And so as we move into treatment and treatment approaches, I hope that all the physicians in the room are appreciating that this is also why people with IACCs have this sort of like often whack-a-mole style symptom profile where you knock one thing down and something new pops up. Because again, that's why we chose the cogwheel model, because these things are interrelated. And if you're just trying to treat one thing without treating the whole system, you can start to worsen some of the symptoms, some of the other symptoms that are emerging, as opposed to treating the whole person. So, what to do about it? I always confess that that the treatment section is a little underwhelming after all of the pathobiology stuff, because the pathobiology stuff is really cool and complex, and we still haven't gotten far with interventions. So I apologize for that, but I also will show you some of the stuff that we're trialing off-label, as well as actively trialing in patients. But before we even go there, I think, the first thing we need to think about is just not to do harm to our IACC patients. If you take, as a medical provider, if you take one thing away from this presentation, if a person with an IACC, you know how to diagnose them now, if they come to you and say, I have post-exertional malaise, understand that this should be the symptom that guides all of your activity recommendations. This should be the symptom that guides all of your treatment recommendations, because this is, again, based on the literature, this is the most debilitating symptom that folks with long COVID with IACCs experience. And so this is the one that we need to try our best to control. And this has not been the case for decades. So we really need to up-level. We need to up-level our understandings, and we need to understand that we've done harm in the past, we've done wrong in the past, and we need to turn over the page and move forward. And I also, want to point out, most importantly, that if somebody says to you that they have PEM, that doesn't mean tell them to lay down in a dark room and do nothing. It means just respect the PEM. So it means find out what the boundaries are that will trigger PEM and help your patients to step back from those boundaries. Because in addition to making sure that you don't exacerbate and you don't do harm, you also want to make sure that you can restore a little bit of quality of life with careful pacing and energy conservation, which we're going to get into moving forward. But in general, our first principles are post-exertional malaise should be the symptom that governs everything that you try and everything that you do. That's the one that we really want to be respecting. And often, when working with people with IACCs, I see a lot of clinicians who are like, okay, we've got to boost your function. We've got to, try this and try that. Often our guidance at our clinic is what we first want to work on is just stabilizing symptoms. If someone comes to us and they say, I don't know why I'm crashing, some days are perfect, some days are terrible, and I can't get out of bed, I don't know anything about why this is happening to me. First goals are stabilize. Let's make sure that someone can actually say, you know what, I do know why I'm crashing now. I crashed because this happened. It's fine. I'll get through it, but I know why. I know why the crash happened. Then we can think about improving function. Then we can think about, strategies that will move things forward. Listen to what your patient is telling you. I've just spent, 20 slides saying we don't have a biomarker. Your patient is your biomarker. Listen to what they're telling you. Have them fill out forms that are gold standard patient-reported outcomes so they can tell you how severe their symptoms are. They can tell you if an interventional approach helped or did not help. And that is the way to move things forward. To that end, prioritizing virtual care, prioritizing home care. If you're thinking about standing up a long COVID clinic, this is a way that you can really take burden off of patients, and you can really avoid unnecessary crashes because someone had to jump in a car, drive to a clinic just to see you. If you can make every effort to do home visits, if you can make every effort to do virtual visits for your more severe cases, this is going to be game-changing. Okay, so moving into some management tools. We're going to start off with pacing and energy conservation, and I'm really going to burn through these slides because I know that we're running out of time. So one of the groups that I want to name is Long COVID Physio. They have incredible resources for pacing and energy conservation. They have them translated for patient resources as well as provider resources in over 70 languages. So this is a really good resource that is free, that is online, that walks you through all you need to know about pacing and energy conservation. In addition to that, I think, I just want to point out that what we want to do is start every rehab conversation with pacing and energy conservation. We want to talk about things like proper hydration. Over 70% of people with IACCs have associated postural orthostatic tachycardia syndrome, POTS. They will respond very strongly to electrolyte infusions. They will respond very strongly to lots of fluids, and we need to keep that going. Similarly, environmental management is a good way of stabilizing symptoms, making sure that people are mindful of temperature. It's not too humid, it's not too hot. These are things that will trigger POTS and trigger fluid loss and make people feel much, much worse. And often folks are not aware of it. So they feel as though they're going crazy because why am I feeling so terrible? And it's because atmospheric pressure has changed. It's because it's a humid day. It's because it's a hot day. And these things are very much linked to symptom burden in a large proportion of IACC patients. Strategies to improve sleep, identifying triggers. I know this sounds really obvious, but again, right back to listening to your patient, sitting down and figuring out what are the things that they tell you will trigger them, no matter how outlandish it sounds. Sit with them, work it out, and work out a strategy to work around those triggers. And then I also, think that linking people up with peer support and social support is crucial. More on that later. Before we move on from pacing, I just want to point out that it's a brave new world. We have smartphone technologies and wonderful tech that can assist in pacing. There are many companies out there that do that. I'm only highlighting Visible because we just completed a publication with them that has been accepted for publication in Nature Digital Medicine. This was the largest study of its kind. We got about 4,600 people with ME and long COVID who had contributed over 100 days of data each. So we had millions of data points. And what we showed was that we were able to predict crashes within 48 hours of the crash happening with 90% accuracy based on their biometrics. So this is a technology that isn't necessarily healing anybody, but it is helping them pace. And when you talk to the Visible folks, they're like, yeah, we're Whoop for chronic illness. That's what we are. Whoop is saying, hey, get on a treadmill and run and do all these things and you're going to feel great. Visible is saying, hey, your heart rate variability is looking a bit wonky. Lay down, take some fluids, and make sure you're in a cool environment. and that's going to avoid the crash. So I just want to name the fact that we do have technologies that can assist with pacing now. It's 2025, and we should be using it. Breath work, again, I just want to point out that this is a low-cost, group therapy-friendly way of significantly reducing symptom burden in patients. We published just last year some of the results of using resonant breathing. So this is parasympathetic breathing primarily. The goal of this breathing was to increase carbon dioxide levels and reduce sympathetic nervous system activity, because we had previously published that folks with long COVID and other IACCs typically have low levels of end tidal carbon dioxide. And so this breath work helps to increase their carbon dioxide levels. And what we saw in 112 patients was people self-reported significant improvement when they engaged in the breathwork program. And they even reported, specific symptoms that were significantly improved from being a part of the breathwork program, and that's been published. And in addition to breathwork, what we tend to do is pair breathwork with our music therapy. I know that music therapy, sometimes you can hear about things like humming and humming therapy, and you can think, well, that seems a bit, not scientific, or maybe a psychological intervention. There's this really wonderful study here that is worth looking into. If you think about IACCs as having a vascular component and having a blood perfusion component, so you're not getting enough oxygen into your tissues, nitric oxide in our bodies is what allows gas exchange in tissue to occur. And humming can increase nitric oxide levels by 15x. So often what we do is we have music therapists working with groups of patients to do both humming therapy and breathwork therapy together. Most certified music therapists are wonderful and know all of this. They know about humming therapy. They know what it does to nitric oxide levels. And so they can lead groups of, 8 to 12 IACC patients in breathwork and humming therapy. And it's a really, again, it's a low cost, low exertion intervention that can give people back a lot of energy. Autonomic rehab, I could do hours and hours on autonomic rehab, but I will suffice to say that we have physical therapists who have trained thousands of other physical therapists on the specifics of autonomic rehab. I would be happy to bring them out here to do proper courses for physical therapists and physicians. But the only thing I want to point out is we have a publication in the American Association of Physical Medicine and Rehab where we really detail some of the guidelines around autonomic rehab. And once again, we're not trying to treat deconditioning with autonomic rehab. So when you sometimes Google autonomic rehab, you'll see Levine protocol, you'll see modified CHOP protocol. These are things where you're up on a treadmill or on a recumbent bike doing aerobic exercise. Autonomic rehab for infection-associated chronic conditions is different. We start with the patient supine lying. We're doing very gentle limb movements. We're pairing those movements with breath work, and we're not exceeding exertion levels of more than 3 out of 10 on perceived exertion scale. So asking the patient how exertional they find the equipment. What I often tell my providers is if your patient is laying there telling you this is pointless, I feel like I'm doing nothing, you got it. That's the level that we're looking for, because again, it's not exercise. We're not trying to enhance cardiovascular fitness. We're doing evidence-based exercises that will retrain appropriate autonomic responses. So what I mean is when someone's doing a heel slide like what you're seeing in the video, their heart rate won't jack up to 20 or 30 beats per minute more by doing this exercise after they've been working with you for 2 weeks. Whereas even if they're laying there saying, I feel like I'm doing nothing, if you're monitoring them, their heart rate's still going up. And once they start with, this is what we call phase 1A of the autonomic rehab process. Once they start there and they stick with it for a couple of weeks, if they're responsive to rehab, we'll see a reduction in how much their heart rate goes up during these exercises. Okay. Medical management. So this is a slide that I keep going on all of the things that have either received, good quality evidence, placebo-controlled RCT. I knew this is your favorite one. I could also share these slides because we're running out of time. There's so much to go through, but the main thing I want everyone to take from this slide is that there are oodles of options of both promising therapies and therapies that have had good quality placebo-controlled RCT data behind them to try out in your patient population for all of the different pathobiologies that could be going on, ranging from persistence to gut dysbiosis and leaky gut, to vascular issues, to autonomic issues, mitochondrial issues, autoimmunity. And if the intervention is underproven, that means that there is a good quality study validating its use in an IACC. If it's under experimental, it's because there are ongoing research experiments looking into the efficacy of these molecules or supplements. But suffice to say, there's so much work to be done. We've got a lot of interventions to trial. And then, if you can imagine it, we also need to go beyond monotherapeutics, and we need to start combination trials of all of these things, because right back to the beginning of all of the pathobiologies that we're seeing are interrelated. A single drug isn't going to do it. We need lots of drugs. And so physicians who are working in can someone delete me saying we need lots of drugs? Physicians who are working in our center, we will have conversations with the patient about off-label use. And it's perfectly acceptable to explore off-label use so long as, you have a paper or a publication that is driving the sort of, rationale for why you might give this drug. So for instance, in the viral persistence column, you'll see that there is the Prigin protocol named, which is a combination of Celebrex and Valtrex, and plus or minus, depending on the IACC you're treating, pulsing Paxlovid. Skip Prigin has published case series of hundreds of patients who have been on this protocol. That's good rationale for trying it out. That's a good rationale for giving it a shot. And so long as your doctor is looking at all of your meds and not seeing an interaction, Celebrex and Valtrex, pretty innocuous drugs that can be tried. And you can start them up one at a time. You can monitor things like liver and kidney function as you go. And so long as a patient is entering into this with informed consent, off-label use is appropriate. Especially given how long, as Chesley was saying, 17 years from bench to bedside, we don't have that sort of time. We need to be trialing these things because there is publications trialing them out. They're FDA-approved drugs. And these days, we also have outlets like Cost Plus Drugs, which we refer our patients to a lot, where if you're making an off-label prescription, they can go on that website and they can get it for a fraction of the cost of if they went to CVS or something like that, and had to pay full price. Final thing I just want to talk about is social support. I think that we just need to, as folks with IACCs are continuing to persist in, I would call it, frankly, hostile environments, we need to really name the fact that loneliness can become an issue. Social isolation is highly prevalent in people living with infection-associated chronic conditions, and loneliness is a huge problem. The literature out there in the world shows us that if you are socially isolated, you stand to have a 30%, 29% greater risk of heart disease, 32% increased risk of stroke. In addition to this, and this is the statistic that always, blows my mind, if you report being lonely or very lonely using the UCLA loneliness scale, it's the equivalent physical health risk of smoking 15 cigarettes a day. So, and the study that did this was a huge population level study with hundreds of thousands of people. and they were measuring things like cortisol levels, and they were showing higher cortisol levels in people who are lonely, which led to cascades of inflammation and hyperlipidemia and all sorts of, deleterious health issues. The reason this is important is that folks with disabilities and IACCs, by and large, are recognized under the ADA as disabilities, are 3 times more likely to experience loneliness, and that can compound health problems. So if if the inflammation, the systemic inflammation and problems that you're experiencing weren't enough, now we've thrown loneliness into the mix, and it's dialing things up, 30% or 40% according to the consensus literature. So this is why we need to address it. To address this right now, what we're doing in our clinic is we're creating social programs for people with IACCs. They're fully funded by insurance, which is wonderful. They're led by social workers. We get 10 to 12 folks with infection-associated chronic conditions together. And basically, the goal of the program, it's a curricular program that runs for 12 months. And the goal of it is, first of all, helping folks to deal with the fact that they've been diagnosed with a disability. So there is an adjustment period that needs to be made. Right now, it's a scary thing. You've been diagnosed with a condition we have no active treatments for, and it has affected your disability status. You're newly disabled. So let's help you adjust to that new reality while we're still kicking ass to try and find, treatments. But in the meantime, let's help you adjust to the disability. The second focus of the group is to actually bring people with IACCs together. So what we actually do is we're able to link people in the groups by zip code so that if they're living within a few blocks of one another, they're in the same group. And so what that does is over a period of 12 months, folks with IACCs start to realize, oh my God, you live down the road from me, or we go to the same grocery store, or we, attend the same church, or whatever the case may be. And at the end of 12 months, what the social worker does is says, I'm starting a WhatsApp group. I'm stepping out of the WhatsApp group, and you all can either stay or leave. But now you've got a little, posse of ride or die friends who you've been through 12 months with, and you live nearby, so you know one another. And so far, over 3 years of piloting the program, it has really improved high-quality, authentic social connections in the groups that have been running through the program. And the final thing that it does, which can't be overstated, is it just gives someone an into the health system. If anyone listening who works for a health system has the same challenges as our health system, people fall through the cracks sometimes. And what this does is you've got a phone number of a social worker, and you can say, hey, my doctor's not texting me back. And then our social worker berates our doctor and says, why aren't you messaging this person back? Or, what can we do to set it up? And that sort of backdoor into the health system helps us not lose patients to follow up, which otherwise could be happening. So I know I've just gone way over time, but I know there was a lot to cover. I just get to talk about the stuff. These are the people who do the work and support the work. So I want to acknowledge everyone on this slide. And I'm sure we got questions. Yeah. Thank you, everyone. And thank you for everyone online as well. Yeah. We got better later on, increased the spin back, and it's better. But the question is that something we should really look at? Yeah. Yeah. So cytokine testing is a very, I think, personally speaking, cytokine testing alone is not a diagnostic biomarker for long COVID or other IACCs, because it's such a moving target as to whether someone will have elevated cytokines or not. The caveat I'll bring to that is that in some cases, inflammatory cytokines can be used inflammatory cytokine levels can be used as part of a machine learning algorithm to diagnose long COVID. So there are people who are out there right now arguing to the FDA that machine learning should be able to be used to make diagnoses. And so, and what that would look like would be, okay, I'm going to take a whole bunch of blood, and maybe your Epstein-Barr virus levels will be through the roof, and your circulating spike protein will be through the roof, and IL-6 is elevated. And a machine learning algorithm will say, yep, that's enough for us to cluster you over here, and we're going to classify you as long COVID. FDA has been a little resistant on that, but people are trying to do it. Yeah. Oh, yes. Yep. Absolutely. So the question was, is vaccination a trigger for long COVID? What I would say, and we're into sticky territory here, and here's what I would say very transparently. Akiko Iwasaki, Harlan Krumholz, and myself, so Harlan and Akiko are at Yale University, I'm at Mount Sinai. We've been studying vaccine injury for 3 years, 4 years now. And what we are seeing is absolutely there is a subset of individuals who have had a chronic health condition triggered by exposure to the vaccines. And we've actually pre-printed one of our first studies on this, and we're trying to get it published in peer review at the moment. We were extremely exacting with the people that we classified as having a vaccine injury, in that what we did was we said, if you tested negative for COVID immediately prior to your vaccine, you received the vaccine, and then you experienced an immediate flare of symptoms that, that never really went away after the vaccine. That was what we characterized as vaccine injury. And we are seeing physiological differences in those folks. And we believe that the physiological differences are most related to circulating spike protein in plasma. And to that end, not only do we think that, it's separate, it's something different, but it's related, which is why I also made that sort of infection or exposure associated chronic conditions, because that would be an exposure. You've been exposed to a chemical that has triggered an immune cascade. But I think it's also why a subset of our patients, and again, this is just me saying something anecdotal as opposed to something peer-reviewed, but a subset of our long COVID patients will say the vaccines, mRNA vaccines, make me feel terrible. And we haven't proven this yet, but I'm willing to bet that the subset of long COVID patients who tell me that probably have a lot of circulating spike protein in their system. And those are the folks that we recommend Novavax vaccines to, as opposed to mRNA. And so we're still team avoid infection and do whatever you need to do to reduce the severity of infection, which includes vaccination as a strategy. But we're also listening to patients. And if a patient tells us that vaccines wipe them out and they feel terrible, we're not going to shame them about that or tell them that they're imagining it. We're going to come up with alternate plans. And so far, our alternate plans have included, more traditional antibody vaccines like Novavax rather than mRNA. Hope that was helpful, even though it's a minefield. Yeah. I think we're just scratching the surface of, and so the question to the audience was, this sort of relationship between anxiety and some other mental health diagnoses and a diagnosis of long COVID, or in fact, other infection-associated chronic conditions. I think we're only scratching the surface of how our neuroimmune axis is affected by infections and who might be more susceptible or less susceptible to things like that. I think that the majority of the literature reporting depression or anxiety being risk factors for an infection-associated chronic condition should really be thrown out. And the reason I think that is because the majority of the literature did this by health record review, right? Now, typically the gap to diagnosis in an infection-associated chronic condition is like 6 to 7 years if you're lucky, if you're in a high medical education setting. If we just focus in on POTS as not as an IACC, but as a condition that is commonly associating IACCs, over 80% of people with POTS first get an anxiety diagnosis before they get their POTS diagnosis. This was work that was published by Dysautonomia International. So when you think about that, and then you think about the methodologies of these studies showing the relationships, they're just doing EHR review. And they're saying, well, look, anxiety is associated with POTS or anxiety is associated with long COVID. Well, that's because someone of indeterminate skill misdiagnosed their POTS as anxiety, 4 years before they finally got their POTS diagnosis. And so not to say that we shouldn't still be looking in the direction of understanding how neuroimmune axis changes can be affected by infection, but just to say that the associations that have been published are really spurious because of diagnostic creep and diagnostic error in the electronic health record. So
Time to ask one more question in person from somebody else.
Okay.
I believe she may have had her hand up.
Okay.
Good talk, thank you. My question is it possible for asymptomatic COVID individuals to then end up with long COVID?
Yes. There have been a number of really good quality studies on this where they were studying basically college kids in college campuses that were testing every day. And regardless of their symptom profile, we knew if they were COVID positive or COVID negative. And although it is rare, asymptomatic cases can result in long COVID. So again, this falls back into the diagnosis. What do we do in a situation like that? I would say our clinic would probably end up diagnosing that individual with MECFS because they would fit into criteria according to the Canadian consensus criteria, because there would have been an event, whether or not they knew what that event was. There was an event, and then their health deteriorated from there.
If we can go to 2 questions from our virtual audience.
Fabulous. We have from Johanna, can long COVID provoke gluten intolerance?
Really good question. What we've seen, speaking generally about infection-associated chronic conditions, is that we see food sensitivities emerging. So what we have not seen very clearly is we haven't seen somebody who was not celiac become celiac after a SARS-CoV-2 infection. But what we have seen is people starting to develop multiple food sensitivities as a result of their long COVID symptoms. And we're trying to better understand that. Part of our team is a registered dietitian who works with patients to understand what their food intolerances are and why. I do think that often what we find the culprit to be is mast cell activation syndrome. So it's a histamine issue a lot of the time. But there's lots of things to think about here, and certainly we can see gluten sensitivities emerging. We also see, carbohydrate sensitivities emerging. My general comment is food sensitivities in general are common in infection-associated chronic conditions, new onset, and working with a skilled and knowledgeable registered dietitian is key. One more.
One more. And Dr. Betts asks, Can we find persistent evidence of an infection without long COVID or other protracted signs or symptoms?
So the question here, if I'm understanding this correctly, is can someone be asymptomatically harboring persistent pathogens? I think is the question. And if the question is that, then the answer is yes, absolutely. And as we start to move into better quality studies around this, and as technology starts to emerge, there's the technique to really look at here is spatial transcriptomics. There's some really amazing work. Some of our collaborators doing this work are from the J. Craig Venter Institute, and I would really recommend taking a look at some of the papers coming out of there. But we do see persistent pathogens in healthy controls. But what is really interesting is when we use techniques like spatial transcriptomics, which don't just find the pathogen, but they also look around the body's tissue and they try and understand, well, is this pathogen just hanging out doing nothing, or is it actively doing something? In the healthy controls, when we see the pathogen, it's just sitting there latent and inert and not interacting with tissue around it. Whereas when we see a person with long COVID, say, and we see a piece of, viral antigen, sitting in the gut tissue, for instance, if we run spatial transcriptomics analysis on that person, we'll actually see that the pathogen is interacting with the tissue around it and causing upregulation and downregulation of genes, local inflammation, etc. So the answer is yes, we can see persistent pathogens, evidence of persistent pathogens that are asymptomatic. And I think that that's a clue, and that's something that we need to better understand.